So when David asked me to co-chair this meeting, he asked Lori Bastian and I to make this a different kind of meeting. That not just like SGIM and Academy Health, as wonderful as those are, and Eve chaired the last Academy Health meeting, which was wonderful. But I think that this afternoon really illustrates how this meeting is different from those meetings, because we are really a community. And we're a community that includes veterans. There's a lot of veterans here. And in fact, there's a veteran on the panel we're about to have. There's patients here. We have a huge presence from our veteran engagement groups at this meeting, which is wonderful. And would you join me in giving a round of applause to all of our veterans who are attending? And could the veterans in the audience please stand up? I know there's several. Yay. Thank you all for being here and being part of our community. You're the reason that we're here. So this meeting includes a lot of members of our community, including, of course, clinicians who take care of patients, the researchers that understand the data, and we all collaborate highly. So there's all members of that community here, which is wonderful. And it's really important to get us together to cement those relationships. And really for us to understand with our operational partners, our leaders, like Dr. Stone and others who were here earlier, what are their priorities? What is their vision for the future? And David and Amy did a wonderful job of sharing that this morning. And now we're really going to hear from representatives of different program offices that partner with us and are users of our research. I want to introduce our panel. First, Dr. Joe Francis is the Chief Improvement and Analytics Officer of VHA. He leads a multidisciplinary staff responsible for integrating reporting and response to identify and remedy variations in quality in the VA. His office combines expertise in data management, measurement, and improvement, and builds enterprise-wide analytics and improvement. He's an avid, I know from experience that he is an avid consumer of research evidence, especially health services research, and a dedicated partner for a lot of us in HSR&D. He's actually the chair of my COIN steering committee. Mr. Fitzgerald, we were introduced to earlier. He's the director of the VA Palo Alto healthcare system. He oversees one of the most complex facilities in VA with over $1 billion budget, more than 7,000 staff, 800 beds, and 7 CBOCs. He's a service-connected disabled veteran. He also told me that he recently underwent back surgery and still made the trip here, so very dedicated person to be here with us today. And last, Dr. Ben Kliegler is the Acting Executive Director of the Office of Patient-Centered Care and Cultural Transformation and the National Director of the Integrative Health Coordinating Center. This office expands veterans' access to a range of integrative health services. He brings his academic medicine background and experience as a researcher to this role as an operational leader. So it's always great to start off a panel asking Joe a question because you get some really interesting answers. And so the first question is for Joe. How do you see research integrated into the work of RAPID, your office, RAPID?
Thank you, Laura. I'll partially dodge the question. You know, I came to VA from a position in quality management and data management in the Catholic health system. And that was in 2004. And my job at that point was director of the Query program, what Amy Kilborn does today. And by the way, probably my best VA job ever. And since then, I've rotated through a variety of acronyms and mail codes. So it was from Query to Deputy Credo to Office of Quality and Performance, which then got renamed Office of Analytics and Business Intelligence. And now I have actually the coolest acronym, which is RAPID, Reporting Analytics and PI deployment. But I feel that in the 15 years, I've really only had one job, which is, from my perspective, it's applied health services research and implementation. And I've had the pleasure to work through that whole trajectory with many of you. I'm on a lot of your steering committees. You probably have a lot of letters of support from me. And the good news is, since I'm actually not a researcher having to constantly shuffle for funds, I can read the stuff that you put out. You guys don't have the time. It's really important. And I have one of my measurement team here with us, Chris Minazzi. He'll be on a panel tomorrow. So, ask him some tough questions. Before Chris was in the role, we had Steve Wright, who actually worked with Laura Peterson in the same shop that included Judy Daly, who started what's now called the VA Surgical Quality Improvement Program. You can see how incestuous we are, but also how important the relationships are. And, again, the mail codes, the acronyms change, but the relationships matter the most. And I still leverage the relationships that were created back in my days in HSR&D. I see Rita has come out of retirement to help with the meeting here, and it's like being in family. But the beauty about the VA system is that we can have these relationships. I could not do that in Catholic healthcare. If I picked up the phone and I asked somebody in another one of our health ministries, say Kalamazoo or Nashville, how do you solve problem X, Y, or Z? You wouldn't get the calls returned, because in private sector, time is money. And so whether we speak of the VA research community or the community of hospital directors or chiefs of staff or service chiefs, we do have a system here, and there's a tremendous value to that system, particularly for what we do in RAPID. Performance measurement really requires rigorous methods. And I think one of the things we are really discovering is that performance measures have unintended consequences. So earlier today, I had a chance to hear Samir Saini from Ann Arbor talk about how do you direct colorectal cancer screening? Big worry for us because we found that the performance measures were incentivizing our clinicians sometimes to make referrals where the benefit was minimal, or not to refer a veteran who may have been outside of the denominator captured by the measure, who still had the likelihood to benefit. Because one of the worst things you can do in a health system is to fly by numbers. Clinical care is a lot more complex, and our performance measures are always flawed. And so we appreciate the ability of health services to tell us where we're wrong and to give us examples of better ways of doing it. Our big struggle right now, I'm now in charge of SAIL, and make no mistake, SAIL has been tremendously valuable for the improvement of our system and to get us over the complacency created by our own press coverage about best care everywhere, which the title really should have been Healthcare Sucks, VA Slightly Better. And we all have a lot more work to do. But there are unintended consequences to SAIL that we're trying to address this year. And Laura's part of the process to help us address that with better methodologies. And some of the unintended consequences are, frankly, a star rating system by creating a forced ranking of sites inevitably creates incentives not for the collaboration, which was what amazed me when I came to VA, but for competition. And sometimes that can get in the way of what veterans need. I was appreciative of John's comments about how we all have to collaborate. It's not within our communities and across our VA communities to make sure that the best care is rendered for veterans. And we shouldn't allow performance measures to get in the way. This problem becomes more distinct now that we have mission. Because in the Mission Act, Congress says VA, compare thyself using hospital compare, as if, we can take their stars and line up with our stars and make some judgments about where veterans should go for the best possible care. The interesting thing is the way to succeed in hospital compare is you focus what you do. Don't do things that are terribly complicated, and by all means, don't be a safety net provider or take care of folks with significant social problems or behavioral or mental health problems, because you will lose a couple of stars for that. And so we just can't simply lay out those comparisons in that raw way. We have to apply that judgment. That judgment has to be informed by research. And we're going to have to communicate that to policymakers and our stakeholders, including media and Congress, for whom long, thoughtful discussions sometimes don't quite work. And so, I'm going to anticipatory way feel Steve Ash's pain from a few decades ago. And I'd say related to that, you all have that opportunity not just to help us, but to help the larger U.S. healthcare system, because, better measurement. We've partnered with the White House and with HHS on this thing called the Quality Roundtable, because we've said, listen, we don't like these measures either. We need better ones, and they need to be meaningful for all citizens, not just for VA. And so I hope all of you, as you do your work now in this more open ecosystem that Mission has created, think about the fact that it's not just impacting the care within VA, but should have a real positive role in the direction the whole U.S. health system takes. Thanks, Laura.
Thank you. Mr. Fitzgerald, maybe tagging on to that question, what do you think are the greatest needs that you have as a medical center director in the era of the Mission Act for researchers to help, and how can we engage with leaders like you?
So I'll tell you, in regards to the Mission Act, we should already have been working on and listening to our researchers in regards to quality, costs, and all the things associated with providing care to a veteran. And so what I see this as a additional opportunity for us to really pay attention and not get caught in the minutia of, you know what, I already know that, and pushing back. The thing is, if you take the data, you listen, you use the data, hopefully the outcomes will be better. And when we look at not being a data-driven organization, right? A lot of people talk about data-driven. That's a key word. Years ago, that was just a word everybody would say, but they would take the data and throw it in their desk. I think now we actually really, really have to earn the veteran's next appointment. And I want you to really think about that. So it's not that, they'll just come to VA, we'll give them secondary care. We never have done that, I don't believe. We've always tried to give them the best care everywhere, or slightly better than everybody else, right?
More than slightly better.
Yeah, more than slightly better than everybody else. But we got to really use the data. If we want to be transformational, if we really want to be relevant in the healthcare arena, we have to act on this stuff. Nobody has more data than VA. We're the largest integrated healthcare system in the United States. Everybody knows that, but we got to act like we're that. When I think about Mission, and I'm going to be talking to Joe after this session about some stuff that we're doing at Palo Alto in regards to data mining with Silicon Valley. We're looking at doing some stuff with Google, some stuff with Verily, and we got some creators signed, and we're starting to work on that. We need to be able to ensure that our veterans get the best care, as you say, internally or externally. So the opportunities are there. We can't wait for somebody to tell us. My thing is, everybody in this audience and all your other counterparts back at the facilities are disruptors. We need you to be the disruption that we need, because without that, VA will no longer exist, because we have other people out there trying to disrupt the system. But again, we are poised to be better than everybody else because of the data and because of our ability and because of all the great minds we have in this room and the other 300,000 employees we have in VA. we can do it. So I guess I would say mission is just something that came, right? I always talk about, what's the next word, what's the next change, choice, and all the other things, fee basis. I mean, I can keep going. But the bottom line is, if we're going to earn that next appointment, we have to do something different, period.
That's good and very motivating. So Ben, you have a really, a pretty unique background. You came from an academic role into VA to leading a program office, and now obviously you're doing so well that you're given more responsibilities. So I think you're a really good person to advise those of us in the room. What's the best way for us as researchers to engage with operational leaders and to make sure that our research can make a difference?
No pressure on that question, though, right?
No pressure.
I think what's been really interesting for me is some of the stuff David alluded to this morning about the difference between the time frame, the timeline of kind of traditional academic research and what the program office needs to propel its work forward. And I think, just to give a quick example, we're engaged with the stand-up of these 18 whole health flagships around the country, which was in response to part of the CARA legislation. And so we're coming into year 3, the beginning of year 3 of a 3-year demonstration project, and we have a report to Congress due in April. And so Barbara Bocour's group in Bedford, who had the fortune or misfortune to be our evaluation partner before all this started, is charged with helping us demonstrate that what we think is a really meaningful and important and transformational concept for VA manifests in specific measurable outcomes. And we don't have a year or 4 years. People don't even want to wait for January. So I'm getting calls now pretty much every week, if not more, from a network director, a facility director, somebody else leading in the field who says, when is the data going to be here to show me that this thing we've invested in is actually working? And I say soon, and then I email Barbara and her staff and say, please hurry up. And I think fortunately we were smart enough with this one to get ahead and design a pretty rigorous sort of outcome evaluation approach before the program really launched. So I think we're okay. But it's not what you're used to in the world of academics. And the other thing that's been really startling is we talk about being an evidence-based system, and I do believe that we are, but the kind of evidence that actually ends up moving the decision makers is not, I hope this is not a shock to anyone, but it's just not exactly the same thing we're accustomed to in randomized clinical trials. And so the question becomes not so much what's truth and is that true or is this true, but really what is needed to move positive change forward for the system and to kind of earn that next visit. And so how necessary is randomization in some of these implementation evaluation studies? I don't want to shock anybody, and I still obviously am engaged with some other trials on the outside that depend on all these things, but where's the control group? Where's the comparison group? How rigorous are we in our demand for the kind of methodology that we're accustomed to in funded clinical trials? Because in the end, the decision makers are really not waiting for that. They really want to know, how is what we're doing now working? Is it accomplishing what we hoped it would? And how are we going to make the next decision, whether that's about budget or staffing or program priorities, et cetera. And so it feels like both kind of shocking in a way from the scientist's point of view, and also kind of an opportunity, a great opportunity, because we're not constrained in some ways by the limitations of the long timeline and kind of somewhat rigid framework of clinical trials. But I think in terms of what do we need from you all as researchers, we need nimble, responsive thinking. And I think we've been fortunate to have that with our partners. And I think one other thing I'll just say in particular from our program office that we need is innovative strategies for looking at multi-pronged clinical interventions. So we know that a lot of our methodologies just don't work for that, a lot of our study methodologies, but the fact is that's what we're doing. And that's what we're going to continue doing, whether it's in mental health or in whole health or in primary care. We're not doing one thing at a time. We're doing lots of things at a time. And so the question is, what's a meaningful way to really look at that? And I don't think we as a research community, even with the advent of PCORI and other growth developments, we still have to push ourselves to tackle that. We have to push ourselves to think harder about how we should be doing that. So that's just a start. I could talk for another hour, but I'll stop.
No, I think that's great, and it echoes what Steve said in his talk about continuing to improve the science of health services research. And a meeting like this helps us see where you need different designs. And I think HSR&D and Query have really responded with more nimble mechanisms for evaluation and partnership with suggestions from people like you.
I just want to add to that
please.
because I so agree with that, and I just think David and Amy have been tremendous, even just in the short time that I've been here, in how they're evolving the thinking about how we should be spending those research dollars. And I think it's really, I'm not just sucking up. I think it's really true. It's hard in research to step away from the methodologies that are considered kind of the respectable scientific approach. So we really appreciate that.
So we have just a couple more minutes. Are there questions from the audience? This is a great opportunity to interact with these experts.
This is for Tony. So I think we've done a good job of our researchers making partnerships with program leads, and Amy's trying hard at the VISN director level. So as a medical center director, are there things that you've done in Palo Alto or that you would suggest that we do that would get help for your local problems, you know, from the research groups that you have? And so if you've found anything that works, could you share that with us? Or if there's things that you don't have that you'd like, can you let us know?
So I tell you, I think I'm blessed at Palo Alto. I've been there 19 years, and I have, I think about all the resources we have, with Steve being one. I mean, just many resources, right? So when we have a problem, I think one of the problems that we have is people are being afraid to ask for help, and then people not wanting to hear what the truth is. You got to remember, I don't know if we have any athletes in the room or people that knows about a playbook, right? So you guys can really give us the playbook. But I'm gonna tell you what Coach Robinson used to say at Grambling: if you don't have the people to do execution, everything stays status quo, right? We have to execute on stuff. I think, again, I have everything. I'm just happy to be at Palo Alto, and I don't know if that answers the question, but I'm gonna keep going a little bit more here. But we have stuff, but you gotta be willing to ask for help if you don't have it, and not suffer in silence. I think that's what really kills an organization, when you suffer in silence and don't act on things and be as nimble as we need to be. Because the thing is, we do a great job as an organization, but we know we have a lot of constraints in front of us, but we still figure out a way to navigate the system, right? Legally, and make sure you put that in the record. Legally navigate the system. So I think any director, I would say any director or healthcare administrator that are not here, maybe they're looking or listening, is that they ask for help and really act on the data. Act on the data. I had to work with Joe here and his team on RAPID, and we made some significant changes. We listened, we did some things. We still have work to do, right? But if you don't listen to sometimes things that you don't want to hear, you can't get any better. And you guys know the answers to a lot of things, and we have to make sure that we listen to those suggestions and act on them. If I can say that, that's the biggest thing I think that can help people. We have to help you help us be successful also.
Well, I love that about listening. That was a message that we had yesterday. And we really want to know what the most effective way as researchers we can listen to your needs. So if each of you, just going down the table, could just give an idea. Mr. Fitzgerald, you look like you're ready to go, so I'll let you go first.
I used to be a defensive end, so I'm going to jump off sides here. But,
Okay. So just talk about how we as researchers can really listen and understand so that we can think about ways to help you with what keeps you up at night.
So I'm looking at Steve here. So Steve, you serve on a couple of our committees at the hospital, right? You need to be at the table. So we need to make sure that we have the research community, which is a part of the VA community, our team, right? So it's not separate. Be at the table with us to help sure that we're making decisions that are driven, again, by data, and we have people there. We've done a lot of things. We stood up Office of Process Improvement really to help us with our thinking, right? We've made sure we have people on committees. We make sure that we call other people in when we need to hear what we need to hear. I think their words should not be secondary in the closet somewhere and they're sending a memo. They should be at the table. And my father used to always say, if you're not at the table, you're on the menu. So we want, so I always got to have a little joke in there. Mary knows me, everyone kind of knows me. But you got to, but really, you need to be at the table to help affect change, and your voice is heard and you hear what the strategy of the facility is right there.
Joe?
One thing for me.
Yeah, well, I have to say a comment that was made by Gerald Cross, who was during a period before Dr. Clancy and before Dr. Shulkin was our EIC. We had some folks in Congress question some HSR&D research. There was a paper that was a little bit embarrassing that came out. I forget exactly the study. It probably was Steve's. And Gerald's answer was wonderful. Actually, it was more of the 10th floor. He says, you know, we pay people to tell us where we stumble.
Mhm.
And I think that's a great gift that you all give. The one thing I would add to that is we now need you to tell us how not to stumble again. And so the research that not just identifies the problem, but identifies the fix is key. And that's what we try to do in RAPID. We thought that performance measurement without an arm for performance improvement was a hollow effort. That's why we changed what we do and how we do it. And we think that's a really good mantra for all of you. So I'm very pleased just with the general shift towards implementation. And there's many more areas where we can do it in.
Ben?
I guess I would say two things. One thing, which I say at some personal peril, is that I think the relationships, at least for me in the program office, with the people in the research community have just been crucial. And so, for example, this is the peril part, being on several COIN steering committees has been great because the opportunity to hear what people are thinking about the direction and where they should go and actually have an opportunity to contribute to that is, I think that's really important, and I really think that creates the opportunity where when someone has an idea and they want to find out if we think it's relevant, they just reach out, and I think that's really great and really helpful. And the other thing I would say, which is not so much from the program office point of view, but I think the partnering with the VISNs is just brilliant because I think the way we're going, have been going, and are continuing to go as an organization is just, you know, program offices are important and we set direction and policy, et cetera, but the VISNs are where it's at. The VISNs are where it's happening. I mean, the facilities are where it's happening, but the connection between facilities and VISNs is much more direct. And so I think for research as an entity to be very explicitly going out and asking the network directors and asking the VISN leadership where they see the priorities. And ultimately that's going to also address our priorities because we can make policy decisions, but it's in this flow out to the field of those policies that they become meaningful. So, and that's where engaging the VISNs in that, I think that's a really great idea, and I think hopefully you're going to keep that going and do more of that. So.
Well, I think this has been a wonderful panel and a wonderful afternoon. Would you join me in thanking our panelists?